My name is Dr. Bardwaj. Thank you for being here. Jenna asked me if I could come give a talk on caring for the caregiver because I think this is one of the hardest jobs there is, very under-recognized. And most of us are going to, if we aren't already, taking care of an elderly parent or a loved one. So just with a show of hands, since we're so intimate, I'm going to involve the audience. How many of you are actually caregivers for an elderly parent or loved one? Okay. What do you guys find challenging about it? Just what is the some of the biggest struggles that you have with that role? Okay, cooperation. I was your parent. I am your parent. Don't tell me what to do. Yeah, exactly. What else? Isolation. Okay. So social isolation is actually one of the worst prognostic indicators there are for longevity, more than things like smoking, hypertension, diabetes, all these things. So that's an interesting one to bring up, kind of a topic on its own. But our role here today is more talking about medications. And now medications are up there as being very, very difficult to manage. Now I use stories. So I am a fairly new father. My son's going to be 3 in October and my daughter is going to be 1 in September. And so my wife and we're both physicians, but we've now taken on this role of caregiver, obviously not for an elderly parent, but so when my children get sick, we have to give them Tylenol, we have to give them ibuprofen if they have a fever. And even us being physicians, did we give the right dose? Is it 3.75? Oh no, that's 3.8. No. Okay. No, no, yeah. And that's us being physicians understanding that that 0.05 ml is not going to make that big of a difference. And that's us with medical training. So it's a very, very difficult thing to do. So these are objectives for today. What we're going to do is understand the why this happened, because a lot of people have this assumption that, medical non-compliance, you're not taking your meds, it's your fault, you're a bad person for doing that. And that's not actually true. There's actual reasons for that. We're going to look at ways we can assess. It's not showing up on the TV. That's fine. We're going to assess risk in your own level because not everyone's situation is the same. We're all unique, different circumstances. And then we're going to find some practical tips that you can use even today to make your lives a little bit easier with respect to medication management. So we're going to talk about some numbers here. Generally, I'm not a numbers guy, but I think it's really important to talk about this up front. 63 million. That's the number of American adults that are family caregivers at some point in their lives. That's literally 1 in 4 adults. Now, that's not all the same in terms of, some families, they live together, so you're taking care of them in the house. Other times it's across states. My daughter lives in Florida and she's helping manage my care while I live here in Texas. But that's a huge number, 1 in 4. So we're all going to do this at some point in our lives. 40%. That's the number of 65-year-olds that are taking 5 to 9 medications. 18% of those take 10 or more medications. That's medications that have their own instruction, their own side effects, their own food restrictions, their own time of administration, route of administration. I mean, you're basically running a company at that point, a logistics operation there. 7 times higher risk of an ER visit from a drug event. Now, that is a startling number. I don't know if you remember a few years ago, it came out that doctors are killing patients. And where that actually came from was this. Medication error is one of the leading causes of death in the United States. About 80% of medication lists that you get from the hospital have a error on it of some sort. That is startling. And so if you're not going to take anything from this talk, if there's loved ones in the hospital, you have to double, triple, quadruple check that list. And then 59% of adults that are 65 and older have limited health literacy. That means basic or below basic. The younger generation is all about wellness and peptides and all this, crazy stuff that really isn't evidence-based, but I'm not going to get into that. But, the 65 and plus generation, this is all a foreign language to them. And they're the ones that are having the most needed care. So these numbers are really important to recognize. So the first thing we're going to talk about is why. Why is medication non-compliance not the fault of the patient, and why it comes up? So physiological change. As we get older, I'm almost 40 now. My knees aren't the same as they were when they were in their 20s. I can only imagine where they'll be at when I'm in my 60s. Now, that also happens internally. Your liver, your kidneys, they are the organs that process medications, and their function goes down as you get older. So medication that was perfectly fine when you were 55 years old is potentially harmful to you at 80 years old, at 85 years old, because you process it differently. And that is the reason why older adults are nearly 7 times as likely to enter the ER. Polypharmacy. We talked about how 5 to 9 medications, 40% of 65 and older are, 18% are 10 or more. These medications all interact with each other. Now, just from a practical perspective, as a physician, I'm an internal medicine doctor, so I kind of have to see the whole picture. But then I send you to a cardiologist, and the cardiologist puts you on a water pill. Then you go see the kidney doctor, and the kidney doctor, your kidneys are being affected, so I'm going to take you off that water pill. And why are you taking that ibuprofen? Then you go see your ortho guy because your knees hurt. They put you on meloxicam. Then, but nobody's talking to each other, right? And so suddenly you're on all these meds, you don't know what to take, and then bang, you end up in the hospital because you're in renal failure, or because you're dehydrated and you're on meloxicam. And polypharmacy is a huge issue. Cognitive change. We're not just talking dementia here. I leave the house and I'm like, did I close the garage? Did I do that? Now I have the app on my phone so I can look oh yeah, I did close the garage. But that's mild memory changes that can affect how you take your drugs. Did I take that med? I think I took it. Wait, no, I didn't. Then suddenly you've taken a second dose, and that's a big problem. And then sensory changes. Vision goes, hearing goes, feeling goes. All these things play a role on whether if you can see the label, open your bottle cap, and all those lead to medical errors. And so this ends up being a self-reinforcing cycle because I'm older, I can't see the label, I take a medication, maybe I took it earlier in the day and I ended up taking it later because I forgot. And suddenly you're like, oh man, I don't feel so good. And then you get tired, you sleep more, then you miss the next dose. And then suddenly, if it was a blood pressure med, your blood pressure is too low. And then the next day, I don't feel good. I'm not going to take that med. That's an issue. I think that's what's causing it. Then you don't take it, and suddenly your blood pressure is 220. Then a week later, you end up in the hospital because you had, God forbid, a heart attack or stroke. It's like, why didn't you take that med? Because it just made me feel crummy. And the reality was that you just doubled up on the dose accidentally, and that's what made you feel crummy. So this ends up being a self-reinforcing cycle. So we blame people, non-compliance. Why are you not taking your medication? There's actual reasons for that. We see this all the time in the hospital with diabetics. They don't take their insulin when they have a GI bug. And type 1 diabetics, that could be deadly. And they end up in the hospital. And I didn't take it for a week because I kept throwing up. You threw up from the GI bug, now you're throwing up because your acid levels are too high. And so it ends up being a self-reinforcing cycle. So I just want to take that stigma off patients that non-compliance is their fault, because oftentimes it's not. They want to follow what needs to be done, but either it's too complicated or they entered this vicious cycle that we need to identify and break it. Now, it's important to understand missed medication is different than medication error. Missed medication is you forgot a dose. Okay, you didn't take it. Medication error is when you take the med, or you take too much of it, or you take a second dose or third dose. But both of those can lead to non-compliance. And it's also important to understand understand oftentimes, our loved ones aren't forthcoming with us all the time, especially if we're not involved with their finances. I can't afford my, medication that the nephrologist ordered me, so I'm not taking it, you know, or I'm rationing it. I'm going to take it once every 3 days instead of every day, or cutting that pill in half. So all these things play a role here. And it's important to recognize those things as the caregiver so that you can intervene and get the help that you need. No one's asking to say you need to solve that problem. No, but you need to bring that up to the physicians and the pharmacists that you go to. So, how do you assess your risk? Everyone is different. So, from a physical perspective, one thing you can do is ask your loved one, can you read that label? Can you take out your med? Can you read it? Because if you can't, that might be a way that you mistakenly take the wrong med or the wrong drug. Can you open it? If you have arthritis in your hands, rheumatoid arthritis, you have the, deformities of your hands, you have these child-proof bottles in houses that don't have children, ironically enough, but you ask them to open it and they just can't do it. That's an area where you can fail. Are you having trouble swallowing? If you notice, if they're drinking, they're eating, they're coughing, oftentimes swallowing troubles is a reason people don't take meds. Everyone says potassium. If anyone's ever taken a potassium tablet, those things are horse tablets. And so people are like, I'm not taking that. I can't do it. And then they crush it. And that's okay for potassium, but some medications you can't crush it. But you're afraid to ask or you don't know to ask, right? So are you having trouble swallowing? Do you have arthritis or does that tremor make it hard to open your bottle? Recent hospital stays. Now that one's really, really, really important here because you go into the hospital and suddenly your whole regimen's changed. Doctors took you off these 4 meds. They put you on these 3 new meds. Your primary care doctor doesn't know. Your specialist doesn't know. And suddenly you don't know what to do because the guy you've known for 25 years told you you need to be on this, this, and this. And suddenly this doctor who's seen you, myself, for like a week is like saying, no, those medicines are terrible for you. So, or 2 days. Yeah, yeah. So recent hospital stays, I think if you take anything from this talk, your antennas need to be up. If you have a hospital stay, that medication list needs to be looked over 2, 3 times over with all your doctors. And then energy levels. As you get older, you get more tired, you're sleeping more, sometimes depression, isolation, right? You brought up isolation. Your energy, you just don't feel like doing things anymore. And that includes taking your medication. So these are things that you can look for physically today. CDC has a steady program, forgetting what that stands for, but basically it's to help, technically it's to reduce falls, but reducing falls usually starts with medications. And so you can go onto the CDC website and look at the steady program. It involves some combination of self-questionnaire, questions, and then some tests that you can do at your Medicare annual visit when you go to your doctor's office. Cognitively, you know, this is one of the hardest things to do. Asking, do you feel like your memory's slipping? No, absolutely not. It's not slipping. What are you talking about? It's not slipping. So it's good to often ask open-ended questions. Is your memory slipping? No. Or how about, do you remember when you need to take your amlodipine? Do you remember when you need to take your this? Can you walk me through your medication routine for the day? And if they can't do that, maybe I need to have them looked at for cognition issues. Trouble with instructions, taking it once a day instead of taking it twice a day, or not even knowing at all kind of how to navigate taking medication. Sometimes you see that in very severe cognitive changes. If they've ever been hospitalized, often they come home confused, disoriented, because there's something called hospital-induced delirium. And so they're not going to know anything that happened within the hospital itself. And so if they didn't have somebody in there with them and didn't have the sign out given to, the caregiver didn't have that sign out given, oftentimes that leads to huge issues. Mood and motivation, we talked about. Screening for depression is really, really huge. Everyone remembers what it was like to live when they were 18 years old, when they had their best friends around them, when they had their spouse around them, and now suddenly most of those people have passed on. Just imagine what that's like, as you're going through life and try to be in their shoes. And then, like I said, health literacy. So it's often important to ask questions like, hey, do you know what high blood pressure is? Do you know why you're on this medication at all? And if they don't know, sometimes if you know the answer, reinforcing that or asking your doctor or pharmacist to spend some time to do that. So things you can look for at home, storage. So I was an EMT before I was a doctor. And so we used to do a lot of house visits. You go to patients' houses and they want you to bring their medications to the ER with them, right? If you see them. I can't tell you how many times we'd go, we'd be like, hey, ma'am, sir, can you give us your medications, and you'd go in and there's this table of like brown pill boxes, just like literally 30 of them. I remember one person literally the whole floor was full of pill bottles. It was just like, these are my medicines. You think this is far-fetched and crazy, but like this is reality. Like these are the things that people are seeing. And you ask them to do a brown bag check, and it's like you'll see expired medications, you'll see duplicate medications. We have trouble enough, like a tovacone and a torvastatin, right? One you use for cholesterol, the other you used as an anti-malarial. And they sound so similar, and so like these things are very, very, very confusing and can lead to medical errors. Dim rooms, right? If the medications are taken in a bathroom that's the lighting's not that great, obviously that can affect how you see things. Your living situation, isolation versus having support around you, obviously those are second set of eyes always reduces medical error. And that doesn't have to be somebody living necessarily, but someone checking in, a friend, a loved one, things like that. Asking about, can you afford your medications? Internet, that's a big one, because oftentimes you're getting messages from doctors, you're getting messages from on your portal, nurses, you're getting pharmacy sending you messages to refill your drugs. And if you don't have internet, you're getting none of that, right? And then language. Obviously, if your primary language is Spanish and all your medications are in English, like that's not going to help you take your medication. And so, how can you assess this while not offending people? Asking open-ended questions like I talked about. Can you walk me through your regimen here? Do a brown bag review. There's a MMAS score. That's a medication adherence scale that they use. They ask 8 questions. It's all self-reported. And if you have a score of 6 or less, that means that there's a pretty high risk of medication non-compliance. Does anyone know what the Beers criteria is? Do you know? Okay, all right, perfect. That's cheating. So the Beers criteria is a list of medicines that are considered harmful for people that are 65 and older. They update it on a very regular basis. Medications that would often cause elderly patients to be confused, medications that would cause them to have low blood pressure, medications that basically can give you high risk of adverse effects if you're 65 and older. And so it's often a good idea if you're picking up medications from a pharmacist, they always ask the question, like, do you have any questions about your meds? And you're like, no, I don't have any questions. It's good to ask once in a while, like, hey, I have questions. Can you tell me if any of my meds are on the Beers criteria? And your pharmacist obviously know what that is. And they'll be like, oh yeah, those two are. And you can be like to your doctor, you're a bad doctor. Why are you keeping me? No, it's like, but at least understand why there's a, you know, with, anyone can shout. It's a pretty intimate setting. What tools do you guys use to help yourselves with this? The dispensers. Okay. The AM, PM. Okay. What else? Pill packs, like the blister packs. Yes. Okay. Medication reminders. Okay. Okay. So you called your loved one and asked them, or? Okay, perfect. So, I mean, it all seems like y'all are using some or all of these, but weekly AM and PM pill organizers. Now, this is very, very helpful if you have good vision and you're able to see. If you aren't able to see as well, if you have arthritic hands, sometimes that's difficult to open. you have the financial means, they actually have automatic ones. They're a little expensive. I think they're like $150 to $200, but they automatically open and then they lock. So like if you open it, take your pills and then close it, it won't open for you again. So that's a way for you to prevent having double medications. Anchoring to routines is really important because, you know, I'm supposed to take iron and vitamin C. I have chronic anemia, but I don't. Oftentimes because I forget to. But anchoring to routines is really helpful. I'm not one who has routines. That's another story. But every day you're brushing your teeth, you have your pill box next to you, you have your medications next to you, anchoring to your meals, right? Some medications need to be taken with food. So just kind of structuring your day around your medications so that it increases your compliance. Now, this one is really important. And I have a particular pet peeve about this one because I'm a hospital doctor and people walk in and I have no idea what you're on. And then I ask, what are you on? And everyone's like, I don't know. My wife knows. And you ask the wife, I don't know. Keep one master list and just have that with you at all times in some way, shape, or form, either as a Google Drive, if there's multiple family members, in your bag, in your phone, rather, if you don't have a phone, in your bag. This is really, really important just to have an up-to-date list at all times, particularly if we remember the polypharmacy thing. If we miss an important medication, you're in the hospital, we start you on one, that opens Pandora's box. And now you can have issues with medical side effects from medication error. Improving visibility, so asking for large print, making sure your medications are taken in a good, well-lit place. Adding a second set of eyes is often very, very helpful. Again, if you're taking care of a family member from you're out of state, that doesn't mean that you need to go in there or FaceTime or Zoom them or whatever. Just a neighbor, a trusted friend, a loved one, just to check in and make sure. Also helps with, the depression, the mood, the fatigue. Someone's coming. You always feel obligated to give them snacks, water, something. It just improves your mood a little bit. And then simplify whenever possible. So, I'm very good at starting meds. I'm really bad at stopping them, right? So that's just doctors in general. But combination pills are there. If a kidney doctor puts you on lisinopril and a cardiologist puts you on hydrochlorothiazide, can you be on a combination lisinopril hydrochlorothiazide? So now instead of taking 2 pills, I'm just taking 1. So these are all things that you can do to try to help minimize the risk of non-compliance. Now, I don't know if you guys know this, but Medicare medication therapy management is a free resource that pharmacy offers you and Medicare offers as a benefit. I didn't know that. As I was preparing this talk, I found that out. So you can ask your pharmacist, ask them like, hey, do I qualify for a medication therapy management referral? Who knows what you can find with that? Area on Aging obviously can connect you with different resources in the area. ACAP can can help you connect you resources in the area. Faith and community centers, they often run free health screenings, clinics, things like that. And then community health workers, particularly if there's cultural barriers, oftentimes are really, really good at bridging some of those gaps. So reaching out to them. And so, some of the technologies, I think we brought some of this up. The automatic dispensers, I'm a big proponent of. I think it helps a lot with reducing medication error. I think you brought up reminder apps, text, phone calls, pharmacy sync. So some EMRs actually sync up now with your electronic medical records, sync up with the pharmacies directly. So as a medication's discontinued, that'll pop up on the pharmacy side and they won't refill it. And medications sometimes that are newly prescribed, it'll sync right away. Shared calendars, often very important. Google Drives, use Google if you can. If you have the capability of using it, they have the ability to make calendars, put a drive in that you're sharing all medical records, sharing all medication lists, all that kind of stuff. And then telehealth, virtual visits. If you have trouble getting out of the house, they're available. Doctors love televisits, so please utilize that. There's no problem in doing that. So some key takeaways that I think I want you guys to be aware of. Aging is a normal thing. If you aren't taking your medicines or you have side effects to medicines, you refuse to take them, it's not your loved one's fault. It's not your fault. It's just normal, but that's okay because we can plan around that. There are tools available to make the assessment easier. Go out, ask your loved one, like, hey, you know, do you don't ask them if your memory's slipping because they'll be like, no. Do you know what year it is? Of course I know what year it is. You know, but there's scores available. The mini cog is another one. That's something that you can use at home. 3 questions that ask them recall. Can you draw a clock with your hands? And I think there's one other thing. That's something you can easily assess at home. And if you have issues there, um, you definitely bring it up to the providers. Small systems prevent big errors. I think that's key. Everybody's life is different. Everybody's means are different. So developing systems that help prevent issues in your unique situation. And if you have trouble knowing what that is, you can reach out to ACAP. You can reach out to your provider. You can reach out to your pharmacist. And then meet every family where they are. I think this is really important, especially for me as a physician, understanding that everybody's means are different. Some people ran, multi-million-dollar companies and other people barely scrape by. Not every shoe fits the same on everybody. So I think we need to understand that, both as a loved one who's taking care of somebody, but also as physician. These are my references, basically used New England Journal of Medicine, CDC, American Geriatric Society, all the legitimate tools that are available to us. So thank you. I appreciate it. Any questions? Yes.
You mentioned the role of people who live in the home. How important is it, especially when they get to an emergency room, to know input from the caregiver?
I think that's probably the most important thing, particularly if someone's not cognitively with it. I just finished an admitting week in the hospital, and the amount of times I have a patient who has dementia, who has no loved one or family member there to tell me what happened or be an advocate, right? Because it's one of these things where you want to do the best you can for the patient, but you don't know what's going on, so it's hard to know what that looks like, right? So you're confused, but I've always been confused, but I don't know that. So that's what I'm treating you for, confusion, right? Versus the person was brought in because, they were slurring their speech or their right arm wasn't working as well. So, these things, it's important, especially in a hospital setting, to have the loved one there and have an advocate with you at all times, just to be able to relay information, but also get information back. So. Mm-hmm.
Real quick question too. Is there a process for these people that have lots of medications to maybe go and have a single person, I don't know, assess to make sure that, this medication's causing this side effect, so you're taking medication to combat that, but then it's affecting, killing your liver or plugging up your kidneys. Is there a process out there where maybe someone can go and just have their medications looked at by a single
Did
person?
you want to add on to that?
What do you think of the gene tag test?
Yes, I am. That's to look at the genetic polymorphism to see if you metabolize certain drugs or not.
Yeah.
Yes.
And whether they work together.
Yes. So I'll get to that one in a second. So I remember when I was in training, and part of my training as an internal medicine doctor is to do internal medicine, both inpatient, outpatient. And then you go to the specialties to do rotations on. So I do a month of cardiology. And every chest pain is a heart attack. And then you go to a pulmonologist, and every chest pain is a pulmonary embolism. And then you go, I had back pain. I herniated a disc. I used to lift a lot of weight and I herniated a disc. My program director was a kidney doctor. So he said, do you have a kidney stone? I was just like, what the hell, man? So each of these specialists, they kind of take your the organ they work on, put it on a, work board, work on it and put it back. Your primary care is the one that's supposed to see the forest for the trees. A lot of us, we want to rely on our specialists because they're more trained, quote unquote, than our internists, your primary care doc. But honestly, your primary care doc is the quarterback. Like, they're the ones that are supposed to be doing that assessment on a regular basis, having those conversations with the cardiologists and the kidney doctors who often fight with each other. I've actually seen it in New York City, punching each other on the floors. I have. So, you know, with that said, the genetic test that you're talking about, I'm a big proponent of it because not everybody metabolizes the same drugs in a particular way. Actually, my wife is a hospice director as well. She works for a hospice company on top of doing what she does, which is amazing. But there was a patient that was on a particular medication, 3 medications, and just the agitation wasn't being controlled, severe dementia on hospice. And then the pharmacist brought up this test, like, hey, why don't we do it? And it's pretty costly. Hospice companies are very notorious for wanting to kind of limit the money they're putting out, but we're like, let's try it. Let's just do it. And so based on that test, we realized that patient wasn't metabolizing 2 of those drugs appropriately. They were clearing out of the system faster than they should. They put them on 1 that wouldn't, and suddenly it was fine. So as we get more and more advanced in healthcare, the more we understand medicine on a genetic level, on a molecular level, because we're not all the same, it'll just get better and better. But the person that would be the quarterback for that would be your primary care doc, and then your pharmacist to a regular degree. That's why they often say it's better to go to a mom and pop pharmacy shop, because you'll establish that relationship and they'll go through that with you, versus the big retailers. They won't know who you are.
One thing I'd like to add about the pharmacy, that was my first thing, is talk to the pharmacist, because I'm sorry, doctors know a lot about a lot of things, but pharmacists know everything about drugs.
Yes, I agree with that.
Super expert. But the other issue is that many people will be getting mail order pharmacy drugs from, say, Optum or Express Scripts, but yet going to a retail pharmacy, Costco, Walmart, Walgreens, whatever, and getting their scripts. And those pharmacies don't necessarily talk to each other. So you need to make sure that if you go to your local pharmacist, your retail pharmacist, that you have the list of meds you're getting from your mail order pharmacy, so they can actually do a comparison study. I use Hippocrates a lot, and there's an app and you can actually do a drug interaction check with all kinds of stuff, because I know weird things.
Yeah. No, I agree. And to be honest with you, in the hospital, I lean on my pharmacists a lot. They catch a lot of stuff, like a lot of stuff. Like, hey, did you know that patient had an allergy to this med, but it was just never done? So lean on your pharmacist 100%. I second that.
I'm sorry, one other thing. I have a comment, maybe a question.
Sure.
I used to own an in-home care company, right? And those people that I cared for that didn't have a loved one, I would offer to take him to the doctor. And it would come time to say, what medicines are you on? And they wouldn't talk about their supplements. They wouldn't talk about their vitamin C and their vitamin D and all that stuff. And I would say, Ed, got to tell him about this. And he's like, no, I don't need to. Why is it important that they do tell everything that's...
Yeah, I think supplements, especially nowadays, because, people are on all these weird sort of supplements that I've never even heard of. There's a good friend of mine, a nephrology friend of mine. He said his testosterone's on the low end of normal, whatever. But he put himself on this stack of like 7 things that are naturally supposed to increase your endogenous testosterone. And I won't know what those are. But if I know that you're coming to me and you're on these supplements, I'm going to study them more to understand how they would interact with you. Example, St. John's wort, something people use naturally to try to improve their mood. If you combine that with a SSRI, you can get for a depression med that increases your serotonin levels. You can go into serotonin syndrome from that. Cinnamon, if you combine with Eliquis and aspirin, you take too much cinnamon, you can get huge catastrophic bleeding from that. So it's very, very important to talk about these supplements that you're on with your doctor. They won't know a lot of them, especially if you're on these weird ones. Peptides are big things nowadays, and we're starting to have to learn what they are because people are using them. Again, the only way we'll know is if you tell us, So.
You know, I was going to make two comments. One with the pharmacy, just like you want to shop for a good doctor, you can shop for a good pharmacist. I mean, Walgreens, during COVID, we had masks on. I walk in and they knew who I was, but it just happened to be that Walgreens. I'm not going to say every Walgreens is like that, but I mean, we shopped for a good pharmacist because of issues. But the other two medication things that I see, doctors tell us to take AM and PM. People assume that means breakfast and dinner. I mean, breakfast and bedtime. So you're getting your blood pressure medicines 8 hours apart, 16 hours you're not getting them. So just make sure you really know what times you're supposed to take it.
Twice a day is 12 hours apart.
Right.
Yeah. That's the way that it's supposed
And
to be taken.
I can't tell you how many people don't know that.
No, yeah, exactly.
And then
That's a good
not
point.
laying down straight after taking medications. I see aspiration pneumonia a big reason, and it's because they're taking their medications at bedtime and then they go lay down and they aspirate it on it.
So one of the worst cases of esophagitis where the esophagus was inflamed was a patient who took doxycycline, youngish person, and then went to sleep immediately. Woke up, they couldn't swallow, excruciating chest pain, thought they were dissecting their aorta. And lo and behold, we end up finding out that the esophagus was just all torn up and inflamed because of pill esophagitis. So if you're taking a pill, don't just lay down, stay upright for at least an hour afterwards. It's not a good idea to take it immediately before you sleep.
You mentioned that the primary care physician is really the point person when it comes to looking at all the medications someone's on, especially after a hospitalization where they may be there for 2 days and then all of a sudden they're on a whole bunch of new medications. Specifically in that case, when someone leaves the hospital, how quickly would you encourage people to take their loved ones or go themselves to see their primary care doctor?
So if everyone in the ER physicians discharge you out of the ER, they say see your PCP in 3 days. I don't know how many of you have tried to call your PCP and said, hey, I need to see you in 3 days. Very rarely does that happen. Ideally within a week. And it's actually Medicare reimburses physicians for something called a TCM visit, a transitional care management visit. And it's very lucrative for them to actually see you within 7 days of hospitalization or within 14 days. So if they're not making room for you on that, they're losing money in their pockets from doing that. But from your perspective, that's the best thing that you can do for yourself is, before it becomes an issue, they can highlight like, oh yeah, we tried this like 13 years ago and it didn't work for you. What makes them think that it's going to work now? And in an ideal world, your physician would come to the hospital and round on you. But these hospitals are businesses. They want their patients out the door by 11 a.m. That's a metric that I get tested on or tested. Like they look at my 11 a.m. discharge rate, my 1 p.m. discharge rate. They look at that. I get a message every morning. What's your ER throughput? We have ER holds. See the discharges first. Get them out so we can get them upstairs. So if your primary care is seeing patients at 8 a.m. to 4 p.m. and they're coming in rounding, that's bad for business, right? It's awful. That's not the way it should be. Absolutely not. But that's the corporate practice of medicine nowadays. And so it's important that you get in with your primary care as soon as possible because they know you. We tried that already. We know that didn't work. You know what? We're going to do this instead.
Awesome. Thank you. I know you're a physician.
Mm-hmm.
Do you have any recommendations on how to encourage our loved ones to follow through with all of these things, to let us help them with all of these things?
Yeah, I think you need to know what motivates them because everybody has a different motivation in life. And so, often just being a supreme pest works wonders. I'll do it if you just shut the hell up,
That's one of my tactics. So.
But I mean, for everybody, it's it's a different motivation and not one size fits all. My good friend and I were discussing this the other day. Things that logistically drive him don't drive me, and vice versa. So I think your experience with your loved ones growing up, understanding their temperament, what they would wake up for and not wake up for, I think you lean on that. But being a pest, obviously, is I'll just do it and just shut up, please. So,
Love it. Thank you.
Speaking of drugs, does everybody realize that if you have Medicare, a Part D drug plan through Medicare, not an Advantage plan, there is actually a payment plan program for some of those expensive drugs like Xarelto, Eliquis, etc., where you can actually enroll with your drug plan, whoever is running your drug plan. And what happens is when you go to pick up that very expensive pharmacy prescription, the pharmacy bills the drug plan, you don't pay, and then the pharmacy plan will then bill you monthly. They'll average out, do some fancy math, and bill you a monthly rate, so you're not having to pay this huge amount of money upfront out of pocket. Because I've also been a hospital case. I'm a case manager too,
okay.
so yeah.
Yeah. So you know the
I
game.
know a lot. Well, that's my own practice too. So,
Oh,
but
wonderful.
one of the infectious diseases docs I used to work with, he would have us call pharmacy plan to see if this particular antibiotic was covered because it was really, really expensive. Because if it wasn't going to be covered, he wouldn't prescribe it because then the patient would be at the pharmacy and not get any antibiotics. So he'd use an alternate medication. But this new drug plan thing started last year. I think
I know about it.
it's
Okay.
it's great because like I said, Xarelto, I mean, $400-$500 for sometimes a month's supply.
Yeah. No, I think the insurance companies are recognizing that out of the hospital is always cheaper for them. So I think you're gonna start seeing more and more resources for the outpatient to help you to help them not have to pay a big hospitalization bill. So.
Well, thank you,
All
Dr.
right.
Bardwaj. We got
Thank you.
little
You don't have to do that.
so thank you. A heads up, our lovely Dr. Bardwaj is going to be starting his own practice at some point. So if anybody is going to be looking for a new
And space is being built out on 121 between Coit and Hillcrest. So in Frisco.
Where are you now?
So right now I'm hospital based, and I work at a number of nursing homes and rehabs in the community, but it's time to branch out and do my own thing. So yeah, my space is being built out as we speak, and hopefully by November or December it'll be up and running. So yeah, so thank you. I appreciate it. Thank you.